Number one, erectile dysfunction is only a problem of aging. True or false?
False, but I'm going to give you a little bit of a stat. It does slightly increase with aging.
Right or wrong? Stress and sleep can affect erections just as much as hormones.
Yes, but the two are very connected. So it's hard to separate them out, but 100%.
Next, true or false? If a man has morning erections, erectile dysfunction is always. Hello and welcome, everyone. Another fun episode on Hormones and Hope, and this is your host, Dr. Makhija. Today is an exciting day for me. I know I always say this for my podcast episodes, but it's exciting because I've received a lot of feedback, emails, DMs that where is men's health, where is testosterone discussion for us, and 50% of my patients are men. So here you go for 2026. We have a very special guest for you, my men, and my women patients for your spouses. I'm going to introduce you to an expert, a medical expert who's a urologist and a sexual medicine specialist, and she's from California, Dr. Katherine Klos. So drum roll here, Dr. Klos. Welcome to our episode. And thank you for accepting the invitation. I'm super, super excited to learn from you on more about men's health, testosterone, erectile dysfunction, and plethora of treatment options or preventive options in this realm of the world. So welcome, and if you have some words for us as to where you come from, why men's health, why sexual medicine as your passion, and then we can move into our questions.
Well, first, thank you so much for having me. I'm excited to be here in California and chatting with another, I don't know what you call them, Californian. As you mentioned, I'm a general urologist by training, and in the last probably about 5 years, have really specialized in sexual medicine for men and women. And while men's sexual health has been studied for a lot longer and there's some more treatment options available traditionally than women's sexual health, men tend not to be as active about seeking care. So I think it's wonderful to extend the topic to a broader audience, especially an audience that may be concerned about hormones or an endocrine background, because as you know, there is a lot of overlap. And erectile dysfunction, sexual dysfunction can mean different things for men, and subsequently really deserves a broad scope of medical, looking into their medical history, medical diet. I think it's wonderful to get the conversation out there. I think it's a great platform for men to be educated about what is going on in their bodies. And for my female patients, because similar to you, I see, female patients as well, it's really great to be educated about your partner's health as well. Because the more that you can work together to be focused on each other's health, I think the better outcome. So, as you mentioned, I'm living in California now. I'm from the East Coast. I've been there, over 20 years, and started in a general urology practice, became more focused on sexual health and hormones in that space, and now out here trying to make Californians a little healthier.
Yes, thank you. I would also invite patients because, when the Dr. Rubin's podcast came on Peter Attia, I was like, oh, I need someone in California. Can someone be here? But, there was more on women's sexual health. But I was really wanting, someone to be approachable. And like you talked about initially when we were discussing about that, what is so special about your practice was that time and the education, and also a specialist as yourself focusing on men's health. If you can elaborate, because many of the individuals don't know or probably think that urology is related to just kidney and bladder and kidney stones and so on. Because when I initiate a referral, that's the usual story. But could you just elaborate on the specialty of urology itself, and then the focus or certain pathologies that are bread and butter or very common in your practice?
Sure. Urology, I think, is a great background for sexual dysfunction and hormones in men and women for a variety of reasons. So, as a urologist, we take ownership of as you alluded to, your kidneys, your bladder, the urethra, the urinary system. We also take ownership in men, and we're starting to a little bit more in women of the genital system. So, the testicles, the penis, the prostate, and that doesn't just involve learning about the pathophysiology of a 45-year-old male. It learn it we learn about development. We learn about embryology. We learn, what how the structures develop, the blood supply, because we are also surgeons. So we learn about blood supply, nerves to that area, because to be able to operate on those spaces, you really want to preserve function, preserve nerves. So the background of urology, I think, is a great setting for knowing more about sexual function. So as urologists, we in general learn a lot about those organs from, start of life through puberty and adulthood. So again, I think that really helps us have the appropriate background. And a lot of what we're doing now for the female space of sexual function is we're drawing on that background and that education, because there are a lot of similarities to help better serve our female patients. So it's a nice place to be. Is it perfect? Of course not. But I do think it gives us, what we do is more than, to your point, a kidney stone or urinary incontinence or prostate cancer. Yes, all of those things are encompassed in what we learn as urologists. But we also learn a lot about the genital system, from an anatomical standpoint to a developmental and hormonal standpoint, along with current complaints or problems of the adult patient.
Yeah, amazing. So I took the privilege, and thank you for accepting that, for this topic of erectile dysfunction and men's health, to divide this or to have two series in our podcast. First, focusing on exactly what is erectile dysfunction and getting through the pathophysiology, just like you mentioned. And then the next part of treatment, and how an expert like yourself, a medical expert like yourself, is evaluating these patients and offering different options in terms of management. So, with that excitement, we will start with our rapid fire. Dr. Klos, whenever you're ready.
I'm ready. I'm excited about this.
Okay. These are either one liner explanations or one word, and then we can dive into in depth, nuanced answers. All right. Number one, erectile dysfunction is only a problem of aging. True or false?
False, but I'm gonna give you a little bit of a stat. It does slightly increase with aging. The prevalence is about 25% in 25 and under, and typically over 50% over age 60.
Number two, yes or no? Can erectile dysfunction or ED be an early warning sign for heart disease or diabetes?
Definitely. And hopefully we're gonna dive into this more. Otherwise, I'm gonna keep going.
Absolutely. Number three, right or wrong? Stress and sleep can affect erections just as much as hormones.
Yes, but the two are very connected. So it's hard to separate them out, but 100%.
Next, true or false? If a man has morning erections, erectile dysfunction is always psychological.
False, for sure.
Okay, people hear this. Number five, yes or no? Is erectile dysfunction more common in men with insulin resistance or metabolic syndrome?
100%. So about 50 to 75% of men with diabetes will have erectile dysfunction. The prevalence in diabetic men is 3 times as common than in men who don't have any insulin resistance or diabetes.
Absolutely. Welcome to endocrinology world.
I know. I was like, yeah, your world.
Yes. Number six, one symptom men often ignore that should prompt medical evaluation.
So I'm glad you asked this one. Morning erections or lack thereof.
Number seven, true or false? Erectile dysfunction is something men should discuss with their doctor as a medical symptom.
100%, because as you alluded to in one of your other questions, erectile dysfunction can precede cardiovascular dysfunction by about 2 or 3 years, when that's a great time for intervention.
Gems here, gems spilling, people. So stay tuned as we now get into the nuanced answers. So Dr. Klos, with this rapid fire, I'm just getting some jiggles here because I really wanted to jump into it even in depth as you were feeling for the rapid fire, but now we have a chance. Number one is, can you just explain what is erectile dysfunction? And the reason I ask this simple question is because it is usually, ED is only associated being as a sexual problem or a sexual issue. But in the endocrinology world, as an endocrinologist, the morning erections that you just mentioned, libido changes are like one of the important questions that I have to make sure it's in my history taking because men won't necessarily just initiate it. Every patient with metabolic syndrome, diabetes, insulin resistance, just weight gain, obesity. So now could you explain erectile dysfunction, why that morning erection specific symptom is so crucial and what are the causes to cause erectile dysfunction?
Okay, I hope your podcast is at least 3 hours. No, I'm kidding. Um, but I think you bring up a really great point, which is what makes urology unique. We are taught from early on that let's say a guy comes in with a kidney stone and we're treating the kidney stone and, this is what we're going to do for surgery, blah, blah, blah. And we're kind of finishing the kidney stone protocol. And we say to them, how are your erections? That is so front of mind in urology. I think, they've done a great job at highlighting that as an importance. It doesn't necessarily carry over to the female patients, but it shows the difference between specialties. Endocrinology, which, has a huge breadth on erectile dysfunction and hormonal dysfunction, yet it may not be as, as one of the top questions versus our field. I feel like guys would come in with very different complaints, and yet we were still asking about erections. So it's a plug for urologists as being great for sexual health providers. But erectile dysfunction. So I think you need to start off a visit with a patient and defining erectile dysfunction from their point of view. I will give you the medical point of view, but erectile dysfunction means different things to different people, as you alluded to. Is it loss of libido? Is it loss of erection? Is it inability to get an erection? Is it inability to maintain an erection? And when you're asking those questions, it's also important to be detailed about it. I have some guys who came in and say, gosh, my erection used to last 60 minutes and now it only lasts 45 minutes. Well, that has been a change. That's different than somebody comes in who says, my erection used to last 20 minutes. Now I'm not getting one at all. Okay. It doesn't mean that both shouldn't be addressed, but it's important to define what the patient is coming in with in terms of a complaint. Okay. So when you think about erectile dysfunction, you've got to think about erectile function first. So at rest, the penis, actually, the arteries within there are constricted, limiting blood flow. When an erection is with stimulation, and we can get into the weeds about that, but with stimulation, what happens is you get dilation of the blood vessels within the penis. So it allows for expansion. So that relaxation occurs in the artery, all right, which allows for expansion. It allows for more blood flow in, all right. So that's great. You have to have blood flow coming in. Now, the complex portion about erections is that when that blood flow comes in, it actually blocks the blood from leaving the penis. All right. So you're getting an erection by increasing blood flow to the penis, and you're maintaining an erection by limiting the blood flow out. When we're talking about erectile dysfunction, there are different areas where you can see problems arise. But really, what you're dealing with, in the end, is either a lack of filling or a lack of storing blood.
Yes, absolutely. It's so clear now. Like we are really looking at what is inducing, what's causing the erection, and what is the base, the anatomy. It's very visual that I could like really understand now, as the way you've simplified it. So now, can you walk us further through it?
Now, when we talk about erectile dysfunction, there are different components or several different components that come into play. One that I think we can touch on somewhat briefly because you are an endocrinologist and this is, a hormonal podcast, but are metabolic factors. So as I mentioned before, diabetes is the second most common risk factor. I didn't mention that, but it's the second most common risk factor for erectile dysfunction. I mentioned the percentage is anywhere from 50 to 75% of men. It occurs about 3 times more commonly in men with diabetes. Why is that? There are a lot of different components there. Some is endothelial dysfunction in the actual blood vessels. Some of it is a little bit of fibrosis also within the vessels. Some of it is neuropathy. So the same neuropathy that diabetic men will have on other portions of their bodies, specifically extremities, will also occur in the nerves leading, pudendal nerve leading to the penis for cutaneous sensation. So you have a metabolic component from, insulin resistance, diabetes. Okay. You also, which kind of bleeds over into hormonal components. All right. So, low levels of testosterone, high levels of prolactin, thyroid disorders, those are the most common hormonal imbalances that we see that contribute to erectile dysfunction. They each contribute to it in a little bit of a different way. Okay. Testosterone will impact sexual function pretty directly. Prolactin, which is another hormone in our body, will inversely affect testosterone and then have a subsequent effect on erections. And thyroid dysfunction can do a whole lot of things to your body. That is your realm. But what it also does is it can interfere with metabolism and disrupt the cascade of sexual hormones. So just that's a little brief component, but you've got metabolic component, you've got a hormonal component, you also have an anatomical component, right? So an anatomical component, you're talking again about blood flow, all right? So are we having problems with getting blood flow into the penis? Are we having problems keeping the blood flow there? So is there venous leaked issues? And are we having problems within the very kind of spongiosal sinusoidal tissue, which is fibrotic and actually can't expand? So that's a fairly concise, but trying to at least highlight the different aspects of what's going on in our body and how that they each can impact erectile function. So really from an anatomical standpoint, what's going on the physical touch space, the hormonal, what's going on in our brain and how that impacts our sexual function. And then the other metabolic conditions, the diabetes. I know high blood pressure is not a metabolic condition, but that's actually the number one risk factor for erectile dysfunction. So there are a lot of areas where things can change in the body and show signs in men's sexual function.
Impressive. Like, look at that, right? Once you look at the anatomy, but number of pathways that are affecting the vasculature or the blood flow. Can I ask you one more question? So, in my practice, when I have individuals coming with these metabolic conditions, like you mentioned, or even a PCP referral for low testosterone, and then you're looking at the evaluation, it's secondary hypogonadism. Long story short, 80% of them, when I look at their etiologies, one of the most common ones that I see now, I would say in the last 5 years, it's just risen, like in terms of the diagnosis, is either sleep apnea or disturbed sleep or, snoring because of, say, some DNS or like deviated nasal system or some obstruction. How often are you noticing that in your clinical practice or just in general in terms of the etiologies? Is that become more and more identifiable and common?
So I think that's a great answer. And that's one of the questions I ask, my patients. And that's why in our practice, it's really important to have the time to ask them about their sleep pattern. Not only are conditions like obstructive sleep apnea, which, can be a sign, have someone, a patient with snoring with it, but disruptions in circadian rhythm are also noted to be associated with poor erectile dysfunction. So it's really important to take an extra look at that aspect of their health as well, because it will impact erections. So sleep and stress tend to overlap. And in terms of pathophysiology and how they affect erections, they can affect erections on the kind of microscopic level from inhibiting nitric oxide synthesis, which is one of the things that you need to have expansion of cavernosal or phallic tissue to get an erection. All right. And if you look at the data, insomnia, sleep apnea, again, like shift workers, this disruption in a more natural circadian rhythm will either have about a 1.23 or 1.5 increased risk in erectile dysfunction than someone who does not. And if you look at sleep data a little bit more, and again, not all these studies are well, randomized, controlled, et cetera, but we're trying to be as data driven as possible. Duration of REM sleep is the highest predictive value for erectile dysfunction. So the more REM sleep you have, the less, erectile dysfunction you are going to have. So I know that may not have answered your question. It was a little tangential. Okay, but I was just trying to highlight like there's a lot that sleep will interfere with, that again, your sign is erectile dysfunction. So erectile dysfunction may not be the, root cause, but it's a sign of what's going on. And that is why my visit is so long, because we got to look at all of these things.
Yeah, so true. So that brings me, since you're talking about the visit, is say you have a 46 midlife man or a 45-year-old, otherwise healthy man as per his history. How do you start? Like, how do you initiate the discussion? What are you assessing? What are you asking? And how does that evaluation look like from a urologist, sexual medicine expert?
So the evaluation, as I've alluded to, is very long. We start with a very extensive history. Very rarely, at least in my practice and in general, is erectile dysfunction associated with a traumatic event. And if it is, the patient typically presents within a few days or a week of said event. So typically what we're dealing with is a longer history of some erectile dysfunction. Thus, the medical history and the temporal outline is very important. All right. So I start with a really long history. We look at sexual history, as we spoke about, are there changes in morning erections, nighttime erections? What is erection quality? What is erection duration? Is there a curvature to the erection? Is it partner dependent? So we take a really extensive sexual history. We also do a systems-based history. So from a urologic standpoint, are there urinary symptoms? About 65% of men with BPH or an enlarged prostate will have erectile dysfunction. We look at cardiovascular history, because we alluded to there's tends to be a correlation between the two. We look at sleep history. We also take a very biopsychosocial approach. What is stress like in life? I mentioned a little bit about sleep, but there's a lot of correlation between chronic stress and sleep and the impacts that has on erectile function. So what is their lifestyle like? What is their work schedule like? An overall, we talked a little about cardiovascular, but overall, what's their body habitus? So we really take a systems-based approach on a history. Want to make sure we look at smoking and alcohol and recreational drugs, exercise, and even overtraining sometimes. So really comprehensive history. And then you want to take a look at medications. Again, things that, would disrupt the, sexual health or interfere with orgasm, interfere with blood flow to the penis. We always, we tend to, like to do an exam, not only focusing on the GU exam, but looking for gynecomastia, for body, body hair distribution, things that might signal hormonal imbalances, weight distribution, blood pressure, if necessary, neurologic component of exam. I'm definitely not as good as a neurologist, but a gross neurologic exam. And then, probably very similar to someone walking into your office, we do a very extensive, if they have not had one done, lab panel where we're looking at not only testosterone, but estrogen and the central hormones, along with prolactin, lipid panel, what their A1C is, thyroid function. We really try to take a comprehensive approach to what their health looks like from a historical exam, laboratory value. And then one of the things to not negate is relationship partner component of things. I alluded that a little bit, but that does have to come into, or not have to, it should, in my mind, come into play when you're addressing any sort of sexual function. So it's a long visit. Lots of different things need to be evaluated, in my opinion. History is really important because that can give us so many clues as to modifiable factors.
That is so neat, right? I echo this sentiment so much with the time and, like really getting into the history. Yes. So it's just a sense of pride that, now we can do that. I mean, compared to, after graduation, if long time ago when I was employed, it was those 5 and 7 minutes. But, this just brings about that pride that, okay, we can do this now. Like actually serve as physicians, the time piece that you talked about, because that's what's helping your patients too.
Yeah. And I think it's really the education. And when patients see that you're looking at all of these different aspects of their life and they can recognize, wow, my sleep may be impacting this, my exercise may be impacting this, you know, small things that to them may seem inconsequential. I think that really, the education piece allows them to understand. And when those two things go together, I feel like the outcomes are a lot better.
Yeah, so beautifully said. Yes. So, Dr. Close, we are going to have our part two where we are really going to dive and learn about lots of treatment options about this condition and what can an individual do, what kind of expertise they need to seek. The last piece that I wanted to wrap up this part one with you was is the initiation of this conversation by both men or their partners. Any words of wisdom for men to discuss this with their partners if they're comfortable versus the couple actually addressing it with the right medical expertise. So, what advice do you have for them to for specific symptoms, seeking expert help, and taking that stigma out that this is a symptom, and I'm just talking about your sexual issue.
That is a great conversation to start with your patient, especially when it's you and the patient, because it can be very challenging for a patient to even ask that question of you, or let alone ask that question of their partner. I tend to direct them, at least initially, in treating erectile dysfunction as a medical condition and not, think about this as something going on with your body, not you're not attracted to your partner anymore. Try to separate the two out. I find it advantageous for them if I'm, just trying to give them a little bit of guidance to ask their partner how they're feeling. Don't lead with, this is really bad or, assumptions, how has it been feeling for you? Or this has been going on with me. Have you noticed? And just that little bit of opening a door, I think, can be helpful. Now, that's my very small take on it. The best out there, and I'm so fortunate to work with a lot of great practitioners, are sex therapists. They are great at speaking with patients, one on one and together to take a deeper dive into what, may be going on that's not physical. And as you know, there's so much that we're learning about how the nervous system, and I could go into that more, impacts erections and how stress and relationships, those will cause change in erectile dysfunction as well. So I think treating it like a medical condition is helpful, not over clinicalizing it, asking some, open-ended questions to your partner about how they feel about it. And if needed, a lot of wonderful sex therapists out there as a resource. And a little bit aside, I do see couples which together for sexual dysfunction. And while that may seem totally awkward, can be really helpful because it takes them out of the equation. I'm the one who gets to lead the conversation and they're responding and interacting, and it's a way to open things up. So when they're, you know, in a maybe a tough spot or they're both trying to come together, it can be really helpful to have either a sex therapist or a urologist, guiding the conversation and pointing out the physical components of things and, distracting from the fact that one may not feel that there's the intimacy or the attraction there that there was before.
Yeah, yeah, this is so beautiful. I just want to remind the audience it's not every urologist. Every urologist does not do this. So, just reframing Dr. Catherine's quotations that a urologist who is also a sexual medicine expert or who has this, specific passion and experience in sexual medicine. So, thank you so much, Dr. Close. I'm again delighted to have you, and I'm looking forward to now the treatment options, how you're going to guide our audience and the community as to what's the next few steps that they can take for men's health or erectile dysfunction. Thank you so much.
Thank you.